So that handles the median nerve compressions high up at the elbow. What about median nerve compressions down low at the carpal tunnel syndrome? At the carpal tunnel and the so-called carpal tunnel syndrome. Well, if you've been in clinical practice or been a qualified medical evaluator for any length of time, you've probably seen dozens or hundreds of cases of carpal tunnel syndrome, depending upon what your practice specialty is. And so let's spend some time now talking about carpal tunnel syndrome. And this is going to be an important discussion because at least in the industrial setting, many times we have cases of carpal tunnel syndrome, and I recently had a case of double carpal tunnel syndrome with surgery on both hands. And as QME doctors, we are called upon to make decisions regarding not only permanent impairment, but also the apportionment of the permanent impairment to causation. And depending upon the particular circumstances of your case, that might be difficult, determining the causation of the carpal tunnel syndrome, because the exact cause of carpal tunnel syndrome is many times unclear. In fact, an exact cause of carpal tunnel syndrome has yet to be fully identified or completely identified. It's known that carpal tunnel syndrome is caused by a combination of genetic and environmental factors. And there are several predisposing factors, including diabetes, obesity, pregnancy, and hypothyroidism. And also, there seems to be some association with heavy manual work or work with vibrating tools, but there is apparently no relationship to lighter work, even if it's repetitive. In fact, the relationship of carpal tunnel syndrome to repetitive activities is still controversial, and carpal tunnel syndrome has not been definitively correlated with either heavy or repetitive manual work. And we'll talk about some references from OSHA that support that finding. Now, the main symptom of carpal tunnel syndrome involves numbness. Numbness of the thumb, numbness of the index finger, numbness of the long finger, and even into the radial half of the ring finger. So a question that we as qualified medical evaluators have to determine is, when we examine an injured worker with carpal tunnel syndrome, is the carpal tunnel syndrome work related? And I want to discuss that in some detail now. And I'm going to be sharing some information with you from OSHA, the Occupational Safety and Health Administration, that sheds some doubt on whether or not carpal tunnel syndrome is related to workplace activities. So let's go through this material, and I'm going to be reading directly from a reference that's included for you in your handout materials, and this is a reference from OSHA, the Occupational Safety and Health Administration. And this reference states the following. It says, the international debate regarding the relationship between carpal tunnel syndrome and repetitive motion in work is ongoing. The Occupational Safety and Health Administration has adopted rules and regulations regarding cumulative trauma disorders. Occupational risk factors of repetitive tasks, force, posture, and vibration have been cited. However, the American Society for Surgery of the Hand has issued a statement claiming that the current literature does not support a causal relationship between specific work activities and the development of diseases such as carpal tunnel syndrome. Okay, so there's one reference, the American Society for Surgery of the Hand, that believes that, at least according to the current literature, there is no causal relationship between specific work activities and carpal tunnel syndrome. And that makes sense, because you can have two workers working side by side on an assembly line doing the exact same tasks, and one will develop carpal tunnel syndrome and the other won't. So what does that mean? That means that the role of those activities may be secondary at most. Okay, continuing on here with this document, says the relationship between work and carpal tunnel syndrome is controversial. In many locations, workers diagnosed with carpal tunnel syndrome are entitled to time off and compensation. In the U.S., carpal tunnel syndrome results in an average of $30,000 in lifetime costs, which includes medical bills and lost time from work. Some speculate that carpal tunnel syndrome is provoked by repetitive movement and manipulating activities, and that the exposure can be cumulative. It has also been stated that symptoms are commonly exacerbated by forceful and repetitive use of the hand and wrists in industrial occupations, but it is unclear as to whether this refers to pain, which may or may not be due to carpal tunnel syndrome, or the more typical numbness symptoms. A review of available scientific data by the National Institute for Occupational Safety and Health indicated that job tasks that involve highly repetitive manual acts or specific wrist postures were associated with incidences of carpal tunnel syndrome, but causation was not established, and the distinction from work-related arm pains that are not carpal tunnel syndrome was not clear. It has been proposed that repetitive use of the arm can affect the biomechanics of the upper limb or cause damage to tissues. It has also been proposed that postural and spinal assessment, along with ergonomic assessments, should be included in the overall determination of the condition. Addressing these factors has been found to improve comfort in some studies. Speculation that carpal tunnel syndrome is work-related is based on claims such as carpal tunnel syndrome being found mostly in the working adult population, though evidence is lacking for this. For instance, in one recent representative series of a consecutive experience, most patients were older and were not working. Based on the claimed increased incidence in the workplace, arm use is implicated, but the weight of evidence suggests that this is an inherent, genetic, slowly but inevitably progressive, idiopathic peripheral mononeuropathy. And what does the term idiopathic means? It means we don't really know what the cause of it is, and doctor, that's where the parties in workers' compensation rely on your judgment and your opinion as to the causal relationship of the workplace exposure and the claimed symptoms associated with carpal tunnel syndrome. So that's what we call upon you for, and that's where your expertise is needed, is in establishing an industrial causation for the condition. Although many studies seem to indicate that workplace factors are not the cause, in California we simply have to demonstrate that it's the workplace activities that contributed to the cause. Doesn't have to be the sole cause, But if workplace activities contribute to the causation of the carpal tunnel syndrome, then at least in California, that qualifies as industrial. Okay, so let's talk about the carpal tunnel. The carpal tunnel is a tunnel. It's an actual rounded space in the wrist. Posteriorly, it's bordered by the carpal bones. Anteriorly, it's bordered by the transverse carpal ligament. Medially, it's bordered by the hook of the hamate. That's medially, and then laterally, it's bordered by the tubercle of the scaphoid. And for those of you that have the handout materials, have a diagram here that shows the carpal tunnel. And it's the carpal bones spanning medial to lateral that form an arched surface, a circular bottomed surface, a rounded bottom surface that's covered across the top by the transverse carpal ligament, and that creates the tunnel through which all these structures pass. As we said earlier, there's a median nerve that passes through there, and then there's 9 finger flexor tendons that pass through this small, closed, non-expansile space. And the carpal tunnel is covered by the transverse carpal ligament, also known as the flexor retinaculum. And the flexor retinaculum is quite an interesting piece of connective tissue. It's quite busy. There's a lot of activity taking place to and from the flexor retinaculum. Medially, the flexor retinaculum is attached to the pisiform and the hook of the hamate bone, and then laterally it's attached to both the tubercle of the scaphoid and the ridge of the trapezium bone. On its volar surface, the tendons of the palmaris longus and flexor carpi ulnaris are at least partly inserted onto the flexor retinaculum. Below the flexor retinaculum, meaning distal, at the distal aspect of the flexor retinaculum, it gives origin to the short muscles of the thumb and the little finger. And by short muscles, we're talking about the thenar and hypothenar muscles. The volar carpal ligament, you've probably heard of the volar carpal ligament, also known as the palmar carpal ligament, is a different structure than the flexor retinaculum. The two are often sometimes confused, but the palmar carpal ligament lies superficial and more proximal to the flexor retinaculum. It's more superficial and it's more proximal than is the flexor retinaculum. And the ulnar nerve and the ulnar artery run through the ulnar canal, which is deep to the palmar carpal ligament, but it's superficial to the flexor retinaculum. And the flexor retinaculum is continuous superiorly with the palmar carpal ligament, and is continuous deep with the palmar aponeurosis. So you can see that there's a lot of activity taking place here, a lot of overlap and continuity of not only connective tissue structures, but nerve and arterial structures as well. And as I said, the flexor retinaculum is crossed by the ulnar vessels and the ulnar nerve above, and the cutaneous branches of the median nerves also cross the flexor retinaculum from above. Now, deep to the transverse carpal ligament, or the flexor retinaculum, whichever term you prefer, pass the flexor tendons of 9 finger muscles. And these include tendons that serve all the fingers, including the thumb. So we have the tendons of the flexor digitorum superficialis to the 2nd through the 4th digits, and we have the tendons of the flexor digitorum profundus also to the 2nd through the 4th fingers, and also the tendon of the flexor pollicis longus. Now, passing underneath the transverse carpal ligament is what's known as the common synovial sheath, also known as the ulnar bursa. And the ulnar bursa is a common synovial sheath for all of the flexor tendons. It contains the tendons of the FDS and the tendons of the FDP. It does not contain the tendons of the flexor pollicis longus because the flexor pollicis longus has its own tendon sheath and does not pass through the common synovial sheath, does not pass through the ulnar bursa. And the ulnar bursa and the common synovial sheath are common synonymous terms. Okay, so this common synovial sheath, which surrounds all of the flexors digitorum, that's plural, flexors digitorum, that's flexors digitorum superficialis and flexors digitorum profundus. This sheath extends downward about halfway along the metacarpal bones, where it ends in blind sacs around the tendons to the index, middle, and the ring fingers. And it's prolonged or continuous on the tendons to the little finger, and usually communicates with the mucous or synovial line sheaths of all of these tendons. Okay, so we're setting the stage now for a discussion of how carpal tunnel syndrome can be caused by tendinitis or inflammation of the tendons as they pass through either the common synovial sheath known as the ulnar bursa, or in the case of the thumb, due to inflammation of the synovial sheath of the flexor pollicis longus, or any combination of all of those tendons. Now, also deep to the transverse carpal ligament is what's known as the radial bursa. So we just described the ulnar bursa. We also have a radial bursa, which is a continuation of the sheath of the flexor pollicis longus tendon through or proximal to the flexor retinaculum to a level of about 2.5 centimeters above the wrist joint, and many different types of configurations of the radial and ulnar bursae exist, and frequently the radial and ulnar bursae communicate with each other. So there's a variety of different configurations. You can have separate and distinct radial and ulnar bursa or bursae, or you can have conjoined radial and ulnar bursae wherein there is communication. In the case of communications between the bursae, inflammation or irritation in any one part can rapidly involve or affect other parts of the sheath, and rapidly contribute to compression of the median nerve due to compression from inflammation of the synovial sheaths. So with tenosynovitis, or inflammation of the synovial sheaths, the whole hand will become edematous or swollen. The palm will be moderately swollen. There may be a feeling of fullness immediately above or proximal to the flexor retinaculum. And with flexion of the fingers using any of the finger flexors, whether we're talking about the flexor digitorum superficialis, or even the flexor digitorum profundus, or even the flexor pollicis longus, flexed fingers would resist return to extension. In other words, these tendons get caught up in these synovial sheaths and have difficulty fully extending. And this is particularly prevalent in the little finger because the ulnar bursa is directly continuous with the synovial sheath of the tendon of the little finger. So the carpal tunnel is a busy place. There's a lot of stuff going on there. Again, there's the median nerve passes through the carpal tunnel. There's 4 tendons of the flexor digitorum superficialis. There's 4 tendons of the flexor digitorum pollicis. There's 1 tendon of the flexor pollicis longus. You got the palmaris brevis and longus muscles and the palmar aponeurosis attaching into it. You have the thenar and hypothenar muscles originating from it distally. Over or on top of the carpal tunnel passes the ulnar artery and the ulnar nerve. Passes the palmar cutaneous branch of the median nerve. And passing also through the carpal tunnel are lots of synovial sheaths, all of which are prone to inflammation and overuse syndromes, and lead to the typical symptoms of carpal tunnel syndrome. Frequent symptoms of carpal tunnel syndrome are both motor and sensory, depending upon which components of the nerve are compressed. Frequently, examinees or patients will complain of frequent burning, tingling, itching, or numbness in the palm of the hand and the fingers, especially in the thumb, the index, and the middle fingers. They'll tell you that their fingers feel useless and swollen, or that they feel clumsy. And you may even look at the hand and determine that there is no swelling, or that there's just a little bit of swelling present, but nonetheless, examinees will complain of feelings of uselessness of their hands and fingers. Symptoms often first appear in one or both hands during the night, and this is especially common because many people sleep with their wrists in weird positions, weird flexed positions. You know, many times when we sleep, we assume or resume positions that we assumed in the fetus, which includes many weird and and stressful positions of the wrist. So that's why symptoms frequently appear during the night. A person with carpal tunnel syndrome may wake up feeling the need to shake out the hand or the wrist, and this is a pain behavior that you may observe during your QME examination. On one of our other programs entitled the Non-Physiologic Exam, we go over an extensive discussion of pain behaviors. And pain behaviors give you some indication as to the objectivity of your injured worker's complaints, and at least with regards to carpal tunnel syndrome, or in cases where there's claimed carpal tunnel syndrome, you would expect to see at least occasional shaking out of the hand or wrist. It's kind of a physical exam finding that's pathognomonic for carpal tunnel syndrome. So be on the alert for the shaking out of the hands sign. So symptoms often first appear at night, and then as symptoms worsen, symptoms start to impose or impress on the daylight waking hours, and people will feel progression of tingling throughout the day. On the motor side, decreased grip strength is a common finding. That may make it difficult for some people to form a fist, might make it hard for some people to grasp small objects, might make it difficult for people to perform other manual tasks. In chronic and or untreated cases, long-term cases, the muscles at the base of the thumb may waste away. Those are the those are the thenar muscles, which is the adductor pollicis brevis, flexor pollicis brevis, and opponens pollicis brevis. And then some people may have sensory disturbances such that they're unable to tell between hot and cold temperatures by touch, and so they suffer frequent injuries and accidents of their hands, including burns. So we have 3 common compression neuropathies in the upper extremity: those involving the radial nerve, those involving the ulnar nerve, and those involving the median nerve. And in each case, compression of the peripheral nerve, whichever it may be, can cause any combination of motor, sensory, and or autonomic findings. And one of the best ways, and one of the easiest ways, and we're going to get into some physical examination procedures here in a minute, but one of the most direct ways that you can determine quickly and accurately which peripheral nerve is involved is by focusing your attention on the function of the hand.